Welcome to Pharmacotherapeutics for Advanced Practice Nursing Across the Lifespan. We will review drugs for hypertension in Chapter 41. Simply put, essential hypertension is common and undertreated. It can lead to health issues later in life when not treated. There is no cure for essential hypertension, and treatment is lifelong. Newer guidelines put hypertension as a diastolic over 80 millimeters mercury or a systolic blood pressure of 130 millimeters mercury or higher. Many people have pre-hypertension and would benefit from interventions such as lifestyle changes. There are many unanswered questions about hypertension, such as how much do you lower the blood pressure and with which agents? Many studies have been conducted to find answers to questions about treatment, but ongoing studies may change those answers. First-line drugs are the drugs chosen to provide the most benefit to the most people, given some guidelines. First-line therapy, or drug of choice, may differ depending on comorbid conditions or patient demographics. Notice the clarifying statements. Normal and elevated consider both systolic and diastolic blood pressure, whereas stage 1 and stage 2 are based on the elevation of systolic or diastolic blood pressure. Essential hypertension has no cause and cannot be cured. It is progressive and occurs more frequently in the older population, the postmenopausal population, and the African American population. Secondary hypertension can be cured by eliminating the cause. There are many risks in hypertension. Some are controllable, others are not. This slide shows some possible causes of hypertension, some of which cannot be changed. This slide shows causes of secondary hypertension. Dealing with the cause can cure the hypertension. Remember that the renin-angiotensin-aldosterone system influences blood pressure and is a system we can manipulate with drugs to control blood pressure. Angiotensin II has a role in several diseases, such as essential hypertension, heart failure, diabetic nephropathy, and renal hypertension. This slide shows where angiotensin II has an effect. The goals of treating hypertension include reducing cardiovascular and renal morbidity mortality, maintaining quality of life, and keeping the blood pressure within guidelines. Lifestyle changes should be employed in all patients. Lifestyle modifications do impact blood pressure, as seen in the reductions in systolic blood pressure expected, as seen here. Just reducing sodium intake can reduce systolic blood pressure by 2 to 8 millimeters of mercury. If you look at the physiology of blood pressure, you can predict where drugs can be used to intervene in controlling blood pressure. When considering drug therapy, drugs work in different areas by different mechanisms, so it is advisable to utilize drugs with different mechanisms when combining drugs to control blood pressure. Refer to Figure 41.1 and Figure 41.2 in your textbook. Remember, arterial pressure is determined by cardiac output and peripheral resistance. Output is determined by contractility, rate, blood volume, and venous return. Peripheral resistance is determined by arteriolar constriction. We have several categories of drugs to employ when controlling blood pressure. Sometimes we cannot reach goals with just one drug. When utilizing more than one, choose from different mechanisms. Remember, usually hypertension is not an emergency, so start treatment with lower doses and titrate to response and side effects. If needed, add a second or even third drug with a complementary mechanism. When choosing the first drug, consider comorbidities. Will the patient benefit from one drug class over another based on comorbid conditions? Can you get more bang for your buck, so to speak, where one drug will address more than one condition? Or is there a class of medications to stay away from due to comorbidities? Refer to tables 41.3 and 41.4 for listings of drugs that help you choose the drugs when there are comorbid conditions and which drugs to stay away from or use with caution due to patient conditions. Here are some tips to consider when treating the elderly. Here are additional tips for consideration in other demographic groups. Note, thiazides have been known to reduce morbidity and mortality. It's a good reason to prescribe them. Angiotensin-converting enzyme inhibitors, angiotensin receptor blockers, and direct renin inhibitors are contraindicated in pregnant females, with the preferred drug choices being methyldopa and labetalol. Beta blockers are useful in preventing the rebound tachycardia when blood pressure is reduced. Another take on first-line therapy, it is evidence-based medication. Some considerations of thiazides based on drug studies. Because we know that hypertension should be treated, it is unethical to subject study participants to placebos. When one drug is compared to another, it is called a comparator study. The purpose is to prove that your drug is better than the competitor's drug at improving control, reducing side effects, or improving morbidity and mortality. Many systems are affected by lack of blood pressure control, and certain drug classes are more effective in minimizing damage in certain areas than others. Such as in the presence of chronic kidney disease, ACE inhibitors and angiotensin receptor blockers are better at minimizing the progression of chronic kidney disease, so these would be a better choice. It is important to consider the entire patient when selecting drugs to treat hypertension. Luckily, we have several categories of drugs to choose from and multiple drugs in each category.